artificial disc replacement in the lumbar spine. What does it mean? Basically, take out the disc and replace it with an artificial disc that can preserve motion. What are the reasons for the surgery? The number one is degenerative disc disease or discogenic pain, which means pain coming from the disc. One of the complex issues in the lumbar spine is determining what's the source of the pain. The discs take up 80% of the biologic, biomechanical weight bearing, so most of the pain and degeneration comes from the disc. And the outer part of the disc is richly innervated, so if you have a degenerated dark disc on an MRI, it can cause severe debilitating back pain. We always try non-operative care first. Our Back Doctor app has the comprehensive non-operative program. But if you've been suffering in back pain for 6, 12 months, 2 to 3 years, and it's really limiting your function and your overall life, it may be worth having an artificial disc replacement. So the artificial disc surgery basically goes in from the front. The approach does not cut any muscle. It goes in between your rectus muscle, so it spares the muscle. We don't go through your stomach. We actually go around the side. All your organs are in a sac called the peritoneum. We don't go through that sac. We go around the side of it so it stays intact. Then we come down on the spine. You have blood vessels that sit on the front of your spine. We have a vascular surgeon typically who moves those out of the way, puts retractors in, and then we do our work. We cut the disc, take all the disc out, clean all the soft tissue and cartilage out, and then put in the artificial disc. Here's an example of an artificial disc. It has a couple pieces of metal with plastic in the middle, and it allows motion to occur. It's a very straightforward surgery. It takes usually about an hour and a half. A lot of people can go home the next day or 2 days after the surgery. You're up and walking right away. Typically, we start physical therapy around 8 weeks after the surgery. Then you do our whole core program on the Back Doctor app to get back to function. General recovery is around 3 to 6 months. So part of the downside to the artificial disc is the artificial disc treats disc pain, but it does not treat facet joint pain, or it may or may not treat nerve pain. Studies have shown it to be pretty effective, especially if somebody has a disc herniation pushing on the nerve. When we go in the front, we can take out the disc herniation, take the pressure off the nerve, and it may treat the nerve pain. But other times, if the segments collapse down and there's scarring of the nerve, there's a chance that the artificial disc may not treat the nerve as well as a fusion, because a fusion does the same surgery, opens everything up, but stops the motion. And that may allow the nerve to calm down better. Here's the counterpart surgery. This is a fusion surgery where we go in the front, put the spacer in, 2 screws up, 2 screws down, lock it in place. The results of both of these surgeries are basically about the same. They're both very minimally invasive, and if the pain is coming from the disc, they both treat disc pain. The downside to the fusion is by stopping the motion, it can put more stress on the discs above and below because they have to move more to compensate. The artificial disc preserves motion, so it can put less stress on the discs above and below. But the artificial disc has more unpredictability to it, such as, is there pain from the facet joints? Is there residual nerve pain? And one of the other more complicated things is after surgery, most of our patients, and the results have been proven in the literature for both of these surgeries, the fusion or the artificial disc, that about 80 to 85% of people get significant reduction in their pain, which is great. They're both great surgeries. The point is they both have really good results if they're done in the right people. The downside is for the 15 to 20% of people that are still having significant pain, what do we do about it? What's our decision-making process? With the fusion, the decision-making process is pretty clear that we shoot x-rays, see is it fused, get a CT scan, and determine is there bone growth in a fusion or not. If there's not bone growth and there's not a fusion, that can explain someone's pain. Therefore, we'll probably do another surgery to get them to fuse, in which case we'll probably add screws in the back and lock it down and fuse the facet joints, and every surgeon knows how to handle that. The downside of the artificial disc replacement is if somebody's still having pain in that 15 to 20% of people, it's very difficult to know what's causing the pain and is another surgery going to help them. So the general answer is if the artificial disc looks pretty reasonable, is don't go back in the front, just fuse them in the back with screws and rods in the back. If the artificial disc looks loose or has a problem, we may want to go back in and take it out from the front and put in a fusion. But the downside to that is these blood vessels, your aorta and your IVC that we moved out of the way to do the surgery the first time, they can be scarred down and stuck down. Moving them out of the way can be life-threatening. Some patients have actually died from that revision surgery. So let me just mention, as compared to the necks, artificial discs in the neck, we're able to go back in and move the throat to the side to change it to a fusion much safer than the lumbar spine where it's the blood vessels, which can be stuck. So if an artificial disc isn't working, we put in the screws and rods in the back to get it to fuse in the back. But sometimes the artificial disc is still moving and we may not get a successful fusion in the back. So the summary is both surgeries, the fusion and the artificial disc in the lumbar spine, the results are about the same. They're both good surgeries if the person has discogenic pain. How do we determine that? MRI, exam, history, sometimes a discogram, sometimes a SPECT scan. Different studies really need to nail down the pains from the disc and not another source. That's key. Make sure they have tried all conservative management first, and then ultimately, which surgery works best, and we do both. Whichever one we think is best for that individual person is what we'll probably recommend. You have two options at this point. If we can help, you're welcome to come see us in person. Please call 310-448-7890. The other option is to email us, and we can get back to you. Email info@watkinsspine.com. Thank you.